to do is just go through and do a lateral skull base overview. You know, you guys are getting lots of lectures, which is good, but the problem is that we don't have the clinical correlation to go with it. So what I wanted to do is try to bring things together that comes in with cases, anatomy, imaging, discussions on what to do with certain cases, and go from there. I've got no disclosures. So from an anatomy perspective, one of the things we always think about with the ear is the fact that it starts out very simple when you're more lateral, and then as you go more medial, it gets more and more complex. And one of the things that I like to stress to my residents is what anatomy do you have, and what avenues do you have to use as either a corridor to address a disease or get to a pathology. And so if we think about the ear, the roof of the ear is the floor of the brain. And if you go far enough medial on the ear, you're going to get into nervous structures. And that's what allows us to be able to use it for a route. So I would pretend that history is absolutely key for skull-based patients. If a patient comes in and says, hey, I've had this progressive left-sided intermittent facial twitching, that should really start to spark a differential in your mind. If they come in and say, I have a slowly progressive hearing loss, my left ear just isn't as good as my right ear, that's one of those things that you know, should tip you off to things. So from my perspective, I think otalgia, otorrhea, vertigo, oral fullness, tinnitus, their hearing status, the otologic history, otologic surgical history, and family history are all very, very important. And these are things that by the time you get done with your history, you should really start to have in your head, okay, I'm thinking X, Y, or Z. If you sit down and you start to take a look at a patient's ear and you're going, I have no idea what, you know, what this could be, you probably should think back about asking some more questions to try to drill down on that. So, you know, you may be there for their ears in a neurotology clinic, but ultimately you want to have a complete head and neck examination. So the big thing for that for skull base is taking a look at their cranial nerves. You know, it's one of those things that there can be little things that pop up. And so taking a look at the extraocular motor function, taking a look at their facial sensation, making sure that they're symmetric with their facial function, and then going through the other lower cranial nerves is a great idea. If you think that you may need to scope that patient, if they sound hoarse, or if you see something red and juicy poking up from below and on your ear exam, then scope them. It's one of those things that, you know, it's an extension of your physical exam. So for ears, I always tell my residents, if there's a microscope in the room and you don't use the microscope, you haven't looked at the ears. That's very important from a chronic ear perspective, but there's little things that you can miss just with a handheld otoscope. The other key thing that you'll need with that is an audiogram. And so what you want to do is see what their hearing is. They're absolutely important because it determines potentially what route that we take, and it also can be very, very helpful in telling you something. If you have a patient with a mixed hearing loss and they describe pulsatile tinnitus, you already know kind of what they're going to be having when they take a look at. So just from an educational perspective, I want to touch on sudden sensorineural hearing loss really quick. Typically sudden dramatic hearing loss, it's interesting. Over the past 6 or 7 weeks here in St. Louis, I don't know if it's just that more people are kind of coming through, but we've had a rash of these, kind of interestingly, with all the viral stuff going down. It's a sudden hearing loss, 30 decibel, 3 frequencies is the board answer. It has an incidence of 1 in 5,000. Patients can present with decreased hearing, fullness, ringing, buzzing, that kind of thing. You always get an MRI with and without contrast to evaluate for retrocochlear lesion. This is actually a gentleman who I took care of who had a sudden hearing loss, saw someone, got treated with oral steroids, didn't get better, saw me for a hearing aid evaluation, and we were like, well, let's get the MRI, let's do our due diligence. And it's rare overall, but what you don't want to do is miss a retrocochlear lesion like that. So if we talk skull base disorders, there's a great variety within skull base. These lesions can range from acoustic neuromas, meningiomas, epidermoids, facial neuromas, paragangliomas, malignant lesions, encephaloceles, CSF, otorrhea. If we're taking all comers, acoustic neuromas are by far the most common, followed by meningiomas. But all these different things are important to think about in they're great things that the boards like to test on because their imaging characteristics are usually so specific that you don't have to open someone up and get a biopsy. You're able to go and plan treatment just based off their radiologic appearance. So acoustic neuromas are benign lesions of the vestibular nerve. Their typical presentation is a unilateral hearing loss. A fun historical thing is that oftentimes there's a discrepancy within word recognition. I always bring that up to residents because, long ago it wasn't easy to get MRIs. And so patients either got CTs or they would even get pneumocephalograms, which sound about as much fun as they are, where patients would basically have air placed into their spinal column. They get rotated around, and depending how the air filled, if there was a big dark spot that didn't fill up the IAC, then there was a probable acoustic. And so one of the historical things is that they would really look to see if there's a difference in word recognition score. These patients can have unilateral tinnitus. They can have some overarching kind of imbalance. These patients can have true vertigo. I would say in my experience, that's relatively rare. It's one of those things that if you have 100 patients that come in the door and say they're dizzy, most of them will not have acoustics. But oftentimes what acoustic patients will say is, when I'm in my backswing or following through in golf, I just feel a little bit off. When I was in fellowship in Louisiana, one of the police officers who worked basically on the boats with all the bayou and everything else on Pontchartrain noticed that he was having trouble on the boats, and he had a unilateral hearing loss, and it turns out he had an acoustic. So the typical presentation for these is on T1 with contrast. They are avidly enhancing. These lesions are unique because they can be very small intracanalicular lesions and then progressively larger lesions. And all the sketches and pictorials that are going to be in this talk are from Dr. Jackler's Skull Base Atlas, which is a fantastic book. And I highly recommend if you have any interest in skull base. And so the big thing with acoustic neuromas is that it used to be horse medicine. If you had an acoustic neuroma 30 years ago, it was, this is what you got, this is what we're going to do. Ultimately, now these patients have more complex options. And I think that that's a good thing. It makes for a longer, more in-depth discussion. But I would submit that this patient has a different conversation than this patient than these patients. And one of the things that patients want to know when they hit the door is, okay, what is this thing? How long has it been there? All those kinds of things. The average incidence of acoustic neuromas, if you want to give someone numbers, about 1 out of every 100,000. They oftentimes do grow. It's about 50% if they're going to grow or if they're going to show. And if they do grow, they grow about 1 to 2 millimeters per year. So overall, they're generally very slow growing if they do grow. I think that's important because the 85-year-old with a bad heart that comes in with a 3 millimeter acoustic is very different than the 1.8 centimeter 20-year-old that comes in with an acoustic. And I think that tailoring those discussions and involving the patient are just very, very important overall. As these tumors grow, they can be intracanalicular, they can be within the CP angle. They're oftentimes a combination of the two. And one of the key points is that the facial nerve will oftentimes get splayed on that tumor. And that's why, if we're going to operate on a tumor, operating on them that are a little bit smaller is always nice to do as opposing to when they're much bigger. As they grow serially, the big thing that we want to make sure that we don't let happen is, because there are certain patients that have good-sized tumors and they won't let you touch them. You want to keep a lookout for any kind of brainstem compression, because patients can end up with basically a obstructive hydrocephalus. There's one patient that's kind of infamous here that has a large tumor. She's in her 40s. She won't let anyone touch it, but she has a shunt. And, it's one of those things that as she's only in her 40s, someone will take care of it at some point. Now, from an anatomy perspective, why patients with acoustics can have altered facial sensation If it becomes large enough and extends far enough anteriorly, it can involve the fifth cranial nerve. And every now and then there will be people that will come in and say, I was shaving and I feel like this side of my face is off. Just something to keep in mind. So this is one of my more favorite clinical kinds of things. This was a 20-year-old student who was enrolled at the St. Louis College of Pharmacy at the time in their 6-year program. So he graduated high school, was doing 6 years undergrad, pharmacy school done kind of thing. And he came in saying, I feel like my hearing's off in my right ear sometimes. It just seems kind of different. If you take a look, he has a little bit of an asymmetry, but it's really not a lot to get excited about. He's got an SRT of 20 on the right, 100% word rec, and he's 10 and 100% on the left. And it was one of those things that we kind of talked about it. And I said, well, your MRI is probably going to look stone cold normal, but something really reasonable to do if you're so, you're busy with life and you're coming in here with concerned about your hearing. And lo and behold, he ended up having a lesion that looked like this. Interestingly, when I asked him if he had any family history of lesions, his mom was getting monitored for an IAC enhancement. We ended up getting testing and everything else and ended up being negative. But it's one of those things that, maybe if this guy showed up on a different day, I may not have gotten the MRI. But it's one of those things I think you always keep your eyes open and keep your antennas up to where if something doesn't sound right, I think it's really reasonable to get an MRI on people with things. I tend to be pretty aggressive with it. So I'm not sure how much capability we have to take questions and that kind of thing from residents that are listening. If we do, what lesion are these? If not, I can just keep rolling.
People can answer on the chat or the Q&A area. You keep an eye out for that.
Okay, but there's the chat. All right, yeah, so yeah, absolutely. So meningiomas, one of the things from these different lesions that I tried to pull and take is that they look somewhat similar, particularly this right here, maybe as an acoustic, but they look different. Meningiomas are the second most common CP angle pathology. They act and behave very similar to a lot of different kinds of lesions, such as the acoustic neuromas. But the unique thing about them is that these patients will oftentimes keep their hearing quite beautifully, and you can have these very large meningiomas, and patients have really good hearing overall, and they keep their hearing for an extended period of time. One of the things that is very common for meningiomas is that they will have a dural tail, like here, right there as well. That will give it away. The other thing people will talk about is say that they look like an umbrella. I always think they look like a shiitake mushroom, but then again, that may just be because I'm hungry. It's one of those things that it's always in the differential for a lesion that just may be in the IAC. But for something like this, it's most likely a meningioma, and you're going to manage it. The big thing with the meningioma is that they have a predilection for forming on certain surfaces that they don't necessarily need to be within the IAC, so they can be more petroclival. They can actually be off the posterior fossa dural covering, which those are actually kind of fun to get taken care of. And then you can have the more kind of typical CP angle extension. This is just a schematic of the predilection that meningiomas can have for certain surfaces to develop. This is why that if you have something that's avidly enhancing up here, it's most likely to be a meningioma versus something like an acoustic neuroma or anything else. So I'll go ahead and give a little bit of history with this. So this was a tool that came in with left side tinnitus, his PCP got an MRI, and this is what it showed. So just to orient people, T1 with contrast, T2, what are you going to tell the patient this lesion is? So it's iso intense and does not enhance on T1, and it's bright on T2. Any takers? So it could be an arachnoid cyst, but you don't know it because unfortunately this patient didn't have a diffusion weighted MRI. Whether that's haste, propeller, whatever your institution uses, that's the question you want to know. Because if it does have a DWI sequence, if it's CSF, it's going to look like CSF. If it's not CSF, it will light up. And so what you want to have is an imaging series that contains a DWI if you're concerned about an epidermoid. Epidermoids are basically nothing more than an intracranial cholesteatoma. They're intracranial lesions that develop secondary to embryologic development. And so they will typically, let me move this chat so I can see all the windows, be dark on T1, and they'll basically follow CSF. The clincher is the DWI, whether that's haste, whether that's propeller, imaging for that. And it typically lights up pretty light bulb bright with them. The history that's kind of key for these is that these patients will oftentimes have kind of subtle cranial nerve findings. It can be patients that say, okay, I have this facial twitching that kind of happens. You get the MRI and then you send your diagnosis. Just from a board's perspective, does anyone know the postoperative issues that that's unique to these patients besides CSF, lead cranial nerve dysfunction? Aseptic meningitis. It's one of those things that it's probably relation to the work on the skin within the CSF. If you get a board question or clinically someone gets surgery for an epidermoid and you look at them very shortly after surgery and go, wow, they look like they have meningitis. It's aseptic. It's most likely aseptic meningitis, and it can be really, really, really to be frank, breathtaking, how sick they can get quickly and then how much better they get quickly with steroids. So the big thing about epidermoids is that they tend to be pushing lesions that push spores, but also kind of infiltrative. One of the big issues is that these patients typically don't present until they're 30, 40, 50 years old. And so getting all of that skin out, it would come at oftentimes too high of a price of having to resect certain things such as cranial nerves, that kind of thing. And so oftentimes these patients will need to have repeated surgery. One of my mentors at Loyola, where I trained John Leonetti, used to joke they wish he could put a zipper on the back of the head of epidermoid patients because it was just one of those things that you have to keep going back in there just to get it taken care of. So let's go through a few more images here. So these are a couple different patients. So taking a look at this CT scan, this MRI, and then this CT scan, we can see that there's unique points to all of them. If we take a look at this CT scan right here, it's a little subtle, but right where the geniculate would be, it looks a little bit funny. And when you get the MRI, you can see that there's a CP angle lesion with an interauditory canal component, but then there's something else out here. And this is what really cinches it for you that this is a facial neuroma. So facial neuromas are rare lesions. If you're talking all comers, you can tell your patients it's effectively 1 out of every 100 acoustics. So it's pretty rare overall. Ultimately, it's important because they can show up at any course along the facial nerve. This right here is one of my favorite pictures because it's a facial neuroma of the descending or vertical portion of the facial nerve as it goes through the mastoid. The interesting thing about this is that I'm a big believer for facial nerve monitoring for pretty much everything but BAHAs, that if you have a patient with a small posterior perforation with a clean, dry ear, you may not get a CT on them, and that's perfectly reasonable. But when you're if you either go transcanal or go post-auricular and you're elevating things, that can be problematic and give you a little bit of heartburn throughout that case. The unique thing about facial neuromas is their management. I personally believe when it comes up to national meetings, I feel that glomus tumors and facial neuromas are always interesting discussions. I think part of it is that there's just not enough of them for there to be a really strong consensus. For someone that has a lesion like this with House-Frackman 1 facial function, keeping an eye on it's absolutely reasonable. If you were to resect that lesion, you're pretty much guaranteeing that patient to a best outcome of a House-Frackman 3. And so for your in-service board situations, facial neuromas, you want to wait for their face to get particularly bad in order to move forward with any kind of intervention for them at that time. One of the key points that I will bring up is a situation like this, and then a situation like this. Now, if we think about taking care of facial neuromas, if we have to operate on a facial neuroma, we want to have a nerve-to-nerve link up. And so if this is growing into the brainstem, the issue will be is that if you have to operate on that patient, there's not going to be anything here. And so that patient would then, you start getting into like 5/7s, 12/7s, cross facials, that kind of thing. And so in monitoring patients, that's just a key element to take a look at. Because, if you think about if this gets to be really large, let's say this doubles in size, well, you're going to have a hard time really getting, a nerve to sew to at the brain stem. And it's one of those things, if that's what you have to do, that's what you have to do, but something to keep an eye on. To keep things moving here, this is a patient that comes in from their PCP because they had an ear infection, and they got the CAT scan, and the small town outside hospital read it as abnormal, recommend ENT. Didn't really put much else on the CAT scan. Anyone notice anything that looks a bit suspicious or a bit off or a bit odd? So left side here looks pretty normal. Right side here, this looks categorically different. Yep. And so on the right side, there's something going on. And if we start talking about pathognomonic imaging things, we can see that you really can't see too much here, but the carotid jugular spine has been eroded, and that in the old days was pathognomonic for jugular foramen lesion. And if we go to soft tissue windows, it shows up really quite nicely. And so, if we start talking about these kinds of lesions, if you see a CT scan with that cut and it looks like that, one of the first things you should think about is a paraganglioma. And that's exactly what this patient had. The ear infection was actually the glomus tumor coming up from the jugular foramen into the middle ear. She also had a mixed hearing loss with large conductive component and pulsatile tinnitus. Interestingly, all of her cranial nerves were absolutely positively intact with everything. And so we'll get to talking about managing those and that kind of thing, but that's just kind of a classic imaging finding for people. So if we take a look at this CAT scan, it's a CT temporal bone with contrast. And if we take a look, there's something here. And it doesn't look really smooth. It looks infiltrative. And in this gentleman's history, when he got sent to me for a right-sided ear infection, he, in discussing, disclosed that he had had Mohs surgery about a year ago. And, the pathology for that was squamous cell. And, you take a look and the skin looks a little migrated back behind the ear. But as I went through his scan, which was obtained, we can see that this mass is really kind of wrapped around everything. And then as we go up, it's going to be wrapped around right where the facial nerve comes out. And sure enough, in the, I think it was like 20 hours that he ended up seeing one of the head and neck oncologists I work with, that he had a facial weakness with it. And he ended up having a metastatic squamous cell carcinoma. His primary Mohs lesion was actually a pinna lesion. And the big issue was that the either perineural or perivascular invasion wasn't noted. He didn't have any post-procedural radiation therapy. And so I particularly enjoy the oncologic oologic skull base cases. And so just to kind of touch on that briefly, because they're not super common, is that there's a number of ways of dealing with temporal bone involvement. You can do a sleeve resection, which is for very limited lesions of, maybe just a little ditzel right there. But I'll be quite frank, the big thing with this is that you really have to make sure that's a limited involvement. These lesions are almost always bigger than what you think. And if a sleeve won't do it, then you can go to a lateral temporal bone resection. And a lateral temporal bone resection basically takes the ear canal and mastoid air cell system out, and your medial specimen wall is the malleus and the eardrum, and everything comes up. It can make for a really nice en bloc resection with a parothidectomy specimen. The key with that is that it also allows you to get the facial nerve out. So if there's anything at the stylomastoid foramen, you can get a negative margin and take the nerve as far up as you need within the middle ear. So that basically gets you to the horizontal segment of the facial nerve, the horizontal segment of the facial nerve, which then you can work on. Total temporal bone resection is something that we don't do a lot. If you do some reading on it, there can be quite a bit of commentary on whether or not it's worth it. Are we just doing surgery to do surgery? I think that's one of those things that it's a larger discussion. I think it's a case-by-case tumor board discussion, but just something to keep in mind as we move through things and move with these lesions. So one of the more common things that we see are patients with Tegman defects, encephalocele, CSF-urea. There's some great papers taking a look at rates of obesity, CPAP use, and Tegman defects. I think that these are all tied together. I feel like anywhere where you have patients who are overweight, you've got CSF leaks or Tegman defects. If you have a patient, I would say the patient that gets a tube and just has oturia, have a very low threshold for sending that off for beta 2. Don't be shy about getting imaging for it. The ones that are nice are the ones that are really beautiful, that you just sit there and you have like a huge whack of bone missing and you see brain coming down, or if they've got a CT or an MRI, that you can actually end up with the brain going down and the adjoining enhancement of the meninges and everything else. I think that there's a lot of these out there. It's a situation of having a high level of suspicion. There's a number of ways to fix these, and we'll get to taking a look at those from there. So in skull-base approaches, these are often done in conjunction with neurosurgery. The approach depends on the pathology, the location of the hearing, and the patient location of the lesion in the patient's hearing. I would say that the big thing to think about within your training, whether it's a skull-base case, anterior skull-base case, whether it's a head and neck case, or any case for that matter, is what's my problem, what's my pathology, and if I do X, what do I get for that? So a mastoid is not a mastoid is not a mastoid. A mastoidectomy for a cochlear implant is very different than a mastoidectomy for chronic otitis media or cholesteatoma. At the same time, saying that, oh, we're going to do a mastoidectomy and that's going to be our translab, well, it's a mastoidectomy that turns into a craniotomy. So in keeping with that, let's talk about translabyrinthine procedures. So translabyrinthine procedures are a non-hearing preservation surgery for lesions involving the CP angle as well as the internal auditory canal. A nice way to think about what their hearing is the 50-50 rule. So if their speech discrimination is under 50%, and or depending how close they get, their pure tone average is under 50 dB, then they don't have very good usable hearing. Now, what does that mean? Basically, can they use a cell phone? If they can use a cell phone on their ear, they've got hearing that's you absolutely should talk about keeping depending on that lesion. If they say, you know what, I can't use a phone on that ear, I can't do anything, and they're at 48 dB and 30% word discrimination, then I think a Translab is a reasonable thought for that patient. So when we talk about a translabyrinthine approach, one of the key points to it is that you can really expose the length of the internal auditory canal, which is great. It's also a approach that really puts you and your neurosurgeon right on the tumor. You basically go straight down and you're on it. It can be used for large tumors. It can be used for small tumors. It does not provide a panoramic view of the posterior fossa. It does a really good job of putting you right into the CP angle as well as the IAC. And how we get there is basically performing a mastoidectomy, but turning that mastoidectomy into a craniotomy. So everyone does it a little bit differently, but at least for myself, that means taking the bone off posterior to the sigmoid, taking off the bone of the posterior fossadural plate, the middle fossadural plate, and then doing your labyrinthectomy, eggshell thin bone over the facial nerve. And then that allows you to have this nice big wide field for when you drill your troughs and then your dural openings for your neurosurgeon to open that up and then be able to get down on the tumor. Again, the big thing about this is that if you have a lesion that's all within, that goes to the distal aspect of the internal auditory canal, it's one of those things that in a translabyrinthine approach will get you there. Or you can do that with a retrosigmoid approach, and depending on the patient's anatomy, you can have a really great result with it. But it's just one of those things to think about what's there, what things get you and what you can get there with. One of the other nice things about a translab approach is that all the drilling is extradural because you're doing all this drilling with the dura intact. So there's a lot less brain retraction, cerebellar retraction associated with it. And so this is a postoperative view, and I'd just like to bring this up for postoperative management of a patient status post a right side translabyrinthine acoustic neuroma resection. And we'll see that there's this ball of very enhancing stuff right here. And this stuff is abdominal fat. And the reason why we use an abdominal fat graft is because this posterior fossa and internal auditory canal dura gets opened. And ultimately, we produce CSF every minute, every day. And if that gets left open, CSF is going to come out. They're going to end up with CSF rhinorrhea. They're going to end up with a seroma of their incision or leakage straight out of their incision. So there's a number of different reconstructions that people can do, the most common being fat. And then some people will use cement, some people use titanium plates. Ultimately, the thing is that as long as you get a good postoperative outcome with a lower rate of CSF leakage, it doesn't really matter. I think one of the mainstays is that you have to fight the fat to really plug that hole. And what happens is that fat gets integrated into that defect and really heals in there and does a really beautiful job of plugging that hole. But it's just something to keep in mind. And when these patients are getting closed up, it's important because you don't want to spend all day doing this beautiful translab, great nerve resection, and then you have all the issues of a CSF leak afterward. So retrosigmoid approaches are one of the two hearing preservation approaches. These approaches are marvelous for CP angle extent of tumors. One of the issues that you can have with them is the extent of intracanalicular extension. So for a retrosigmoid, we're going to be behind the sigmoid right here. And so the placement of that sigmoid can be important with how much exposure that you get. And one of the key things that differs from the Translab to the Retrosigmoid is it gives you a much more panoramic view of the posterior fossa, which can be really, really nice depending on where a lesion extends. So these are the lower cranial nerves right here. This is 5 here. And so how do we get there? Well, this is performed with a craniotomy posterior to the sigmoid sinus. The keys and exposure is the transverse sinus and the sigmoid sinus need to be exposed, or some people even decompress them a little bit. At that point, the dura gets opened up, and the most important aspect is letting off the CSF to let the cerebellum relax. If that cerebellum starts jumping up at you, it's one of those things that that's kind of the train that leaves the station and doesn't stop. So you want to make sure that everything gets relaxed, and that allows you to get to a good point with your tumor exposure. So this is kind of the initial tumor exposure. And this really illustrates the part that you can get to internal auditory canal extension with a retrosig. It just depends how much extension do you have. I think we can all look at this picture and say if the tumor stopped here versus going distal to this area, well, that makes a very big difference. And it makes a difference with your hearing preservation. Using your imaging, you can take a look at how far it extends into the internal auditory canal. And it's something where if it extends a great deal into it, I think it's worth having the conversation with the patient going, well, this is how it extends. There could be a chance of getting into the inner ear with the tumor extent, with how far it extends distally. And it's just something to consider. Again, for our part with drilling these, it's drilling troughs inferior and then superiorly, and really trying to skeletonize the internal auditory canal 270 degrees to allow for better access to it for tumor resection, and makes the job easier for nerve preservation. Middle fossa is the third approach, which preserves hearing for acoustic neuromas. Middle fossas are unique because instead of going from behind the ear, we basically go over the ear. These are for, in most cases, small tumors that are not extending out of the internal auditory canal. There are places that do a lot of extended middle fossa, and if they get a great result, that's awesome. One of the big things with that, though, is that if you're going to go after something that extends out into here, it may require cutting the tent, which brings up other discussions and concerns with things. I think it's interesting, at least in my practice, a lot of patients that have good hearing with small tumors want to keep an eye on them. And as long as they're willing to get their imaging initially at 6 months and then yearly after that, I think it's an absolutely reasonable thing to do with that. One of the key points and considerations with this is the fact that it may not be quite this grand, but there is temporal lobe elevation with it. And unlike a middle fossa for encephalocele repair, you're not lifting it up and pulling on it for 40 minutes, 30 minutes, 20 minutes, that you're lifting it up while you're doing drilling, while you're doing tumor work. And the question is will the patient tolerate that? So a patient who's 75, 80 probably is not as good of a candidate for a middle fossa as opposed to a 23-year-old, 25-year-old kind of thing. The other key difference is that your view is going to be differently. So whether it's in the temporal bone lab or getting the ability to go in on encephalocele repairs, middle fossa anatomy is one of those things that you really just can't see too much. So I'd really recommend every chance you get, make sure you get a chance to take a look at that. So for encephalocele repair, there are lesions that you can fix via a transmastoid approach. But a lot of the time, these patients will have multiple dehiscences and the skull base looks like Swiss cheese. And so in our practice, we typically do middle cranial fossa, where we perform our craniotomy, get it flush with the cranial floor using the zygomatic root as our identification for that. And then lifting up the dura and identifying those areas if there's any encephalocele, addressing that, and taking it step by step from there. A couple of the neurosurgeons I work with actually like to open up the dura and do an intradural repair as well as an extradural repair. it's one of those things that I don't think that you necessarily have to. You can use vascularized tissue to fold that in. You can put the bone flap down as another layer. I think it's one of those things that depends on the size of the lesion, the size of the defect, the location of the defect, and what you're working with. If there's any concern of any kind of infectious process, at the same time, vascularized tissue can be really nice to be able to fold in there and proceed with a repair such as that. So for this is a large petroclival meningioma, and I would submit that a retrosig is not going to get you there. A translab isn't really going to get you there. So that's where an approach called a combined Petrosal can be helpful. If you think about it, it's basically combining a middle fossa and then the potential for a retrosig, a retrolabyrinthine, or a translabyrinthine, retrolabyrinthine being just behind the labyrinth if they've got good hearing. And it gives you a much wider expense with that. The big thing is the tent has to be cut, so the abducens nerve and the vein of Lebet have to be kept in mind with that. And it gives you a nice wide perspective to the skull base to get a look at that. And that can be really helpful, especially for petroclival meningiomas. This is a transodic approach. The facial nerve has been mobilized here, and then we'll notice that the cochlea is gone. This is really good for more anterior lesions. The big thing to always think about if you're working on the cochlea and drilling it out, the cochlea rests on the carotid arteries, so that's not going to be very far away with that. So facial nerve presentations, typically it's more of a posterior presentation for acoustics. Meningiomas, or anterior presentation, excuse me, for acoustics, and it can be posterior presentations for meningiomas. Ultimately, you don't want that posterior presentation. They're decidedly rare because when we work on these acoustics, we like to sweep, make sure the nerve isn't there, and then work within the tumor, have a capsule, and then the goal is to have that capsule really just peel off with that. That could be a whole nother grand rounds on tumor resection between subtotal, near total, and gross total resection. But I think it's important to try to get a gross total resection. So facial nerve disorders, we see a lot of these patients. I like to put this patient up because, for the residents to discuss of what their House-Brackman function is. Oftentimes people will say, well, it looks like he gets some eye closure, and that's because he's young. I can tell you he's a House-Brackman 6 clinically and surgically, because he actually got stabbed with a knife that skived along his mastoid tip and cut the nerve at the foramen, and we went in and got them taken care of from that perspective. But for young patients especially, it's just very key to keep in mind that they may be able to have near complete eye closure. You take a look at the whole face and take it step by step. Your disorders can range from a Bell's palsy, trauma, iatrogenic, facial neuromas, facial hemangiomas, or malignancies. If they have pain and their face is out, you need to really look for that tumor and take a look and be aware of cutaneous malignancies, especially in patients who are immunosuppressed. And another patient with facial weakness, they can be kids, they can be adults. You've got different pathologies associated with those at times, but you need to keep a high level of suspicion up. I'll conclude this. Stay safe, be well, keep reading. And there's my email if anything comes up, and I'll take any questions. Thank you all for your time.
Thank you so much. Appreciate it.
Yep, thank you. Appreciate it. Take care.
Thank you.